Hello, I'm Dr. Amanda Woodworth, a breast surgical oncologist with Keck Medicine of USC at Henry Mayo Hospital in Santa Clarita Valley. The first thing that I do is assess the patient to see if they meet the National Cancer Guidelines or NCCN guidelines for genetic testing. If they do, and we can identify a genetic mutation in them or their family, we can better characterize what is their exact risk for developing breast cancer as well as other cancers. From there, all high-risk patients who have a lifetime risk greater than 20% are recommended to have a screening mammogram and a screening MRI every year. It's typically recommended that we stagger those every 6 months so that their breasts are imaged every 6 months, and if anything were to occur, we can catch it as early as possible stage. From there, I break all high-risk patients into low high risk, which is typically about 20 to 30% lifetime risk, intermediate high risk, which is about 30 to 50% lifetime risk of developing breast cancer, and high risk, over 50% lifetime risk for developing breast cancer. For the low high risk, we work on mainly those interventions that we talked about before, which are what are the risk factors that you can change. For the intermediate high risk, we apply all of those along with the increased screening, as well as start talking about maybe risk reduction with medications that can decrease their lifetime risk of developing breast cancer by giving them an anti-hormone. Commonly used ones are tamoxifen for premenopausal women or aromatase inhibitors for postmenopausal women. For the high risk patients, I start to discuss with them about a risk reduction mastectomy. If you are found to have a lifetime risk greater than 50%, it does not mean that you automatically have to have your breast removed, but we can at least start to look at what is the best plan for the individual. And we typically don't start thinking about a risk reduction mastectomy until that lifetime risk is greater than 50%.